Okay, today we're going to cover chapter 17, and it's cardiovascular emergencies. So we need to go over a little bit of the anatomy, just to reiterate the information that we already know. Let's see if I can find it. There you go. Okay. Okay, so this chapter's based on cardiovascular emergencies. It's not that long, and I can tell you right now, it's hot like hell, even in the shade. So stay cool, stay inside. I know that I was talking to one of the doctors, and they were telling me that they've been getting some cases of heat exhaustion and heat stroke. So we'll eventually go over that when we start dealing with environmental emergencies. I think this is the only chapter we're going to cover today. And then I'll post it up as soon as we finish the class. So as of right now, do you guys have any questions? Okay.
No.
Let's get started. So heart disease is the America's #1 killer. And basically all it is, this is a broad term that deals with anything that happens right now. If you really think about it, when you die, your heart stops, right? So every single case in America should be heart related or whatever. Heart disease can also lead to a chest discomfort and cardiac arrest. Because of potential consequences, the EMT treats all patients with signs and symptoms of cardiac compromise as a cardiac emergency. And I remember at one point or another when I was studying to be a paramedic, I went to a conference, and one of the guys I was teaching, I think it was a 12 EKG class, mentioned this, and I thought, well, that's a good enough, perspective, that if you actually get your finger and put it in the middle of the chest and put it smack in the middle of your chest, okay, and 1 foot circumference, any discomfort, pain, or issues that are there, considered a heart attack unless proven otherwise. So your thing is to pre-treat and prove otherwise. So sometimes you don't have the chance to actually prove otherwise, but you have to pre-treat. So you give oxygen, open up the airway, give oxygen, and then basically give a couple of medications that we normally give for chest pain. Okay. The circulatory system has 3 major components itself: the pump, which is the heart, the tubing, which is the blood vessels, and the blood, which is the fluid. So all those have to be working and intact. If you have any leaks anywhere, whether it's because of a laceration or a rupture, or it's just because of oncotic pressure that's causing all the plasma to go outside, then you're gonna have an issue. I know that when we were doing surgeries, one of the doctors that I helped with one of the surgeries basically told me, "Hey, if you don't see a bleed anymore, let me know, because 2 things: I fixed it or the heart stopped." With such a calm demeanor, it's like, okay, let me check. So once your heart starts pumping, there's not going to be any bleeding. Okay, the circulatory system, the conduction system, generates electrical impulses that actually stimulate the contraction of the muscles of the heart. Now, what it is that we have a fine, synchronized pump that will actually pump blood throughout the whole system, but it's got its little, what do you call it, perks to it. And we have these little cells. Let me see if I can draw it. I can go with black this time. So this is the heart itself, the atrius, and the ventricles. Okay. The sinoatrial node is located right around this region. And all it is it's not a dot, it's just an accumulation of concentrated cells that actually will conduct electricity, or what we call bioelectrical bioelectricity or biochemical electricity. So what happens, it does this by actually causing the what they call the sodium potassium pump. Okay. And I remember this joke that they told me when I was taking chemistry. Um, yeah, I got a minor in this deal, so in a major in biology. Of course, you have the negatives and positives. So they asked somebody, hey, I think sodium asked potassium, hey, do you want to go out? Okay. And then potassium asked sodium, hey, how about we go get some pizza? Nah. Okay, well, you have to be there. We're younger. Everything was funny. So anyway, so you have this deal called a sino-atro node that's located right here. Now, what it does, it's got, I don't want to say it's tracks because that would make you believe that it's basically little strands, but no, it's got specialized cells that will actually go throughout both atrias, okay, and cause them to contract. Now, in between the atrius and the ventricles, we have this tissue, okay, and this tissue, what the hell? This tissue here is called the fibrous annulus. Now, I don't know, there's one end or two ends to it, and I believe it's two ends. So I don't even think I spelled it right, but you have to think about it. Whenever you have the heart, well, let's say any muscle tissue, let's say you get a piece of muscle and you put it on a table and you apply electricity so it can contract. The only thing it's going to do is contract, right? So what causes it to actually have movement or produce movement or do anything?
Blood.
No, it has to have a fixed point. Let's say if the muscle that goes from my shoulder to the bottom part of my arm and I tell it squeeze, what it does, it's attached to this bone and it causes it to actually move up. And then we have an opposing muscle over here that will actually do the same thing. While this one relaxes on top, this one contracts, and it causes me to have this type of movement. Okay. Now, in the heart, think about it, it's just a muscle. So if a contraction relaxes, all it's going to do is squeeze and do nothing. But it has this tissue here, which is a fibroid tissue or fibrous tissue, not fibroid. Fibroid means that it looks like, but it's not, that actually doesn't conduct electricity. And these muscles on top are connected to this, and the muscles on the bottom are connected to this. So whenever you have a signal, the atrias themselves, the first place of contraction would be right here on the right atria. Okay, and then it transports. Now, of course, you have like a millisecond. So what happens is the atrius will squeeze from the top to the bottom. Okay, and then the signal gets to this fibrous annulus, and it doesn't do anything. It doesn't transverse unless you have a pathology. So what happens is that you have the fibrous annulus going here. I mean, the signal going to the fibrous annulus, and it doesn't happen. But we do have like a little opening right around this region right here, causing the atrioventricular node to basically branch out. So the atrioventricular node eventually gets the charge, and it starts the bottom process. So there's a slight slowing down from the atrius to the ventricles. Now I can't find it in any book, but that's the way I kind of understood it from reading all these medical books. So basically, at this point, the signal goes from right here, and the first thing that it hits is your bundle of his, but then you have the septum itself between the ventricles themselves having this first part of the signal. So what happens is the heart itself will actually be pulled up this way. Because if this contracts, it pushes up the muscle itself. So the first thing that happens is that if you think about it, it squeezes up. Okay, so what it does, it squeezes up, and then that charge goes around to the Purkinje fibers, so it squeezes up, and then it closes. Squeezes up, and then it closes. So the reason I'm telling you is because a lot of pathologies can be understood if you understand the way the heart actually contracts and relaxes. So let me kind of erase this a little bit. So let's see, we have the heart again, the atrius, and the ventricles. Okay, the left ventricle itself is connected to a tube called the aorta. Okay, and I'll show you in a picture. The first two little outlets that are right here. I'm sorry. Well, yeah, they're actually right around this region. It's because the ventricle goes a little bit higher. Right here, and the valve is located on the bottom of it. Sorry, no, I was going to draw it on top. On the bottom of it, uh, when the ventricle squeezes, it pushes blood, and it goes through this little valve, which is called the aortic valve, and it causes blood to go into the aorta. Now, what happens is that the aorta itself kind of if you think about the aorta being like this, ascending, transverse, and descending aorta, it bulges out, but it's got a contractile type of thing. So what happens when it bulges out, kind of squeezes back in. So when it squeezes, it pushes blood a little bit back, causing these valves to close up. So now the valves close up the aortic valve, and it causes blood to go back and then go through those two little outlets that we have there. And these outlets are what actually is what starts off the coronary circulation, which is what your heart gets fed with. So you're going to see that a couple of terms, and we're going to talk about them in just a little bit, which basically I call it, well, in simple terms, they're called contraction and relaxation. Okay, so in more medical terms, we refer to them as systolic and diastolic. Okay, remember, when we have the pressure of that gulp of blood hitting against the blood vessel, that is your systolic blood pressure. And whatever you have left is your diastolic, right around this region. So the aorta has a squeezing mechanism so they can push the blood further. Now, the older you get, the stiffer the blood vessel gets. So if the aorta does not expand when you're sending blood through it, what's going to happen? It's going to have a hard time trying to push the blood. So you're going to be suffering from a higher afterload than you're supposed to. So ideally, the numbers that we play with is 80 to 120 millimeters of mercury, and that it's in itself is what actually causes the contraction to go back in. It has to be 80 to 120. Anything above that, you're going to have a hard time from the ventricle to push against that pressure that's going through here. That's going through here. So there's a sinoatrial node, our atrioventricular node, and the Purkinje fibers, and that's what kind of causes the heart to actually squeeze. So remember, the ventricle squeeze downward, and then in, and then the atrioventricular bundle of His and Purkinje fibers will actually squeeze up first, causing the bottom part of the heart to be pushed up in this direction. And then through the Purkinje fibers, then you have the contraction of the walls of the heart itself. So it squeezes up, and then it squeezes in, causing blood to actually flow. The sinoatrial node likes to shoot at 60 to 100, which, what does that number remind you of? 60 to 100. It's a normal pulse rate of an adult, right? Easily. So 60 to 100 is a normal pulse rate. So that is controlled by the sinoatrial node. The atrioventricular node will tend to shoot from 40 to 60. And the Purkinje fibers is below 40. Excuse me. So if for whatever reason your sinoatrial node does not want to work, doesn't work, there's a secondary mechanism. The atrioventricular node here will shoot at 40 to 60. So if you find somebody that has a pulse rate of 40, or let's say 50, assume that it's a ventricular rate until you prove it otherwise. And how can you tell, how can you tell it's going to be a ventricular rate versus an atrial rate? When you put them, I know this is a little bit advanced, but supposedly we're supposed to be teaching basics also of this thing. When you have your electrocardiogram, a P wave signifies the sinoatrial node, also known as a ventricular, an atrial contraction. Then you have a negative deflection, positive deflection, negative deflection, and then a T wave, which is kind of big, but so this is the P wave, the QRS complex, and the T wave. If you remember your alphabet, P, Q, R, S, T, right? Have you heard of the term, they have a STEMI, which basically means that they're having a heart attack or ischemia? Well, STEMI basically means there's an ST right here, these two, elevation. So normally we like to play around with this straight line called the isoelectric line. Oh, kind of screw that one up. So that's the isoelectric line. If there's any deviation, then you have to worry about what's causing the deviation.
Okay.
So sometimes the isoelectric line can go all the way over here, so then you get to see this. Or it can go all the way from right here and then just go to the T wave. That's an ST elevation, ST depression, basically meaning heart attack or ischemia, right? And how can you tell the difference between them both? If you give them oxygen, nitro, and aspirin, and if it goes away, then it was ischemia. If it doesn't go away, there's a good chance it's a heart attack. That's just what do you call it? A way to actually differentiate between those two. Let's go to the next one. So you have the sinoatrial node located right here, and then you have the atrioventricular node that's located right here. I'm sorry, right? It shows it right here. And this is what your fibrous annulus. If you notice the fibrous annulus, you can't tell it, but it makes up the valves. So the valves are a different tissue than the heart itself. The atrioventricular valves. You have your mitral and the mitral and the atrioventricular, it's because I'm looking at atrioventricular node. So basically you have the mitral and the bicuspid, or tricuspid, I'm sorry. So basically that's the way the heart itself kind of pumps blood out. And I'm gonna show you just in a little bit. The heart has its own property of automaticity, which basically means the cells can actually fire and cause their own rhythm. But heart rate can actually be influenced by the sympathetic and parasympathetic nervous system. So Have you heard of the term adrenaline?
Yes.
Okay, adrenaline basically is when you get scared, your pulse goes up. Well, adrenaline is it's a hormone that's actually released by the suprarenal glands, which are the glands that are on top of the kidneys, what I like to call the beanies of the kidneys. And basically, what happens is that they release, and that epinephrine, or in actuality, is not epinephrine; it's actually adrenaline, causes the heart rate to go up. But then, when you start getting into the reverse portion, which is the parasympathetic, the parasympathetic slows it down. Anyways, if you want to remember it, just remember parasympathetic. ¿Para qué? Just remember ¿para qué? Like you just gave up, so it slows down. Okay. The heart cell pumps blood throughout the body. The left ventricle must overcome the pressure in the aorta to eject blood. Remember, it has to be 80 to 120. Anything above 120, the ventricle itself is going to have a hard time pushing that blood out. Excessive pressure in the aorta over time can actually lead to heart failure and pulmonary edema. In other words, once your heart itself starts becoming a lot larger because it's having a hard time, so it's retaining more blood, so it becomes bigger in the ventricles. That's called cardiomegalia. And what happens is that once the heart itself stretches out, it doesn't have the strength that it used to have to actually squeeze blood. So you have a weaker ventricle. And the blood flow basically goes from the superior and inferior vena cava. And also we have this little section here that they don't show. It brings back blood from the coronary circulation. It takes it through the tricuspid valve into the right ventricle, which then it pushes it out to the pulmonary arteries. Remember, an artery is defined as any tube that goes away from the heart. A vein is defined as any tube that comes back to the heart. So this one's going away to the lungs, they get oxygenated, and then come back from the pulmonary veins to the left atrium, which now squeezes to the mitral valve or the bicuspid valve, and then that itself squeezes blood through the aorta and first hitting the the aortic semilunar valve, and squeezes out to the rest of the body. So the if you notice in this picture, the left side is thicker than the right side because this one has to squeeze blood all the way throughout the body, and this one has to squeeze blood just to the lungs. So the issue is like most heart attacks will occur in the left ventricle because it's the one that utilizes the most oxygen. It's doing all the work. So basically, this is circulation. It takes it to the lungs, gets oxygenated, brings it back to the heart, then it squeezes it out through the aorta, and it goes into all the tissues, all the cells in your body, and gets the carbon dioxide and oxygen exchange. The vessels themselves, you have arteries, arterioles, capillaries, venules, and veins. Now, you might think the capillaries, they're small, whatever. You know that capillaries control a lot of the blood pressure. If they close up, your blood pressure actually increases. So one of the medications that we give is nitroglycerin, right? When we give
Yes.
nitroglycerin, what it does, it dilates the muscles and the capillaries, causing blood to actually expand a little bit more. I mean, the blood vessels to expand a little bit more, bringing down the blood pressure. So nitro is a peripheral vasodilator, and by peripheral means the most distal portions of the blood vessels, which is the capillaries. And of course, you have the major blood vessels that we deal with in the human body. I'll let you guys look through these. Let me see if I can actually just make this picture a little bit bigger. Okay, let's see if that works. So basically, you have the aortic valve. The aortic valve separates into three blood vessels, which you get to see right here. I'm not gonna do it in red because red is the color that we have. I'll do it in I could do it in my room. So this is one of them right there. There's the other one, and there's the other one. And of course, this is the aortic arch itself. So basically, ascending means going up, transverse going across, and descending means going down. So we have three blood vessels right here. You have right subclavian artery, which starts from right here, and it goes to the bottom of the clavicle, and it goes to feed the right arm. Then we have the, oh, let me erase this because I can't see. Then we have this middle one here, which is basically goes to the, what are these blood vessels called? Well, this one right here, carotids. Okay. Now the subclavian, the right subclavian actually separates and goes to form into the right common carotid artery, which then goes into the brain and feeds the brain itself. But in this one, we have the carotid, and then of course you have this one here, which is your left subclavian artery, which goes below the clavicle itself, and then goes down to the arm. Okay, the descending itself will start feeding into the kidneys, the esophagus, and all those good little organs that we have in there. And it separates right around this region until once we get to the pelvis section, they become femoral arteries. Oh yeah, so once we get past it, I'm sorry, I meant to say get past, they become the femoral arteries at this point. Okay, so I mean, well, you guys need just to go over this because we don't have enough time in the world to actually cover the whole thing. And the veins is that right? It's like the same thing. Whenever you have a blood vessel, I mean an artery, there's always going to be a vein next to it, and sometimes there's going to be a nerve tract next to it. I remember arteries take blood away from the heart, veins bring it back. Okay, so the circulatory system, the vessels themselves, the heart muscle is perfused by the coronary arteries. Occlusion on any of the coronary arteries deprives the heart muscle from any oxygen and nutrients. So you develop a heart attack, heart failure, or abnormal cardiac rhythms, which is also known as a dysrhythmia. I'm gonna tell you the heart itself, the heart muscle is such an excellent muscle, and it's got its own uh, mechanism of actually contracting and relaxing by itself. That if for whatever reason, and think of the heart muscle being a little kid in an HEB right next to the candy racks, which is very conveniently put right when you're leaving the store at the level of the kids. And if the kid tells you, "Mommy, I want a candy," you turn around and say, "Yep, not gonna happen." Or like my son says, "Nope." Um, then what happens is that it starts having a fit. If the heart muscle starts having a fit, that becomes a cardiac dysrhythmia. So what do you do? What is, whenever you see a Mexican telenovela and they're actually having a lady starts getting frantic and starts getting into a hissy fit, what does the gentleman usually do in the telenovelas? Which I love
Slap
Mexican
her.
telenovelas. They just slap him across the face. And what does the lady do? Calms down, right? What's the same thing? We actually, the heart starts having a little hissy fit. We slap it, but we slap it with shock, with electric shock given out by the automated external defibrillator, also known as the AED. So whenever you shock the heart, you are causing the heart to go into a systole. And a systole, all it means is cardiac standstill. And you hope it resets itself, like Control Alt Delete in a computer. You hope. I remember for the first time I shocked somebody, it seemed like hours went by and nothing happened. I just saw him going like straight line, like in the TVs. And I was looking at it, it's like, okay, come on, kick in, kick in. When I looked at the the documents, it only took about a second or so for it to hit back in. But I mean, I was so first time you shock somebody and you start thinking, I just killed this guy because shocking somebody causes him to go into cardiac standstill. I mean, luckily we weren't wearing white pants at that point because I would have shown my shame. I would have pooped in my pants. So basically, you shock it so you can actually have it go back into a normal rhythm. Now, remember I told you about these blood vessels that leave the aorta in the first section? They're right. Where are they? Can't even focus. I just have my eyes dilated right here. And these blood vessels go around, making the right coronary artery and the left coronary artery, and then they turn around and they connect, but then they have branches that go downward. And now I want you to think about this. Every time this coronary artery bifurcates into two, they become smaller. So you have a little clot that's traveling and it fits through here, but once it gets to think, it gets stuck right there because the the vessel became a lot smaller. And you can actually have a portion which basically can actually be ischemic. Like right here, you have the left coronary artery. Remember, the left side requires more oxygen because it pumps blood all over the system. And the valves, the semilunar valves are located right here. Um, if a clot goes into this section right here from the left coronary artery to the anterior ascending, well, the anterior ascending is wider. I mean, it's skinnier, or I want to say smaller than the left coronary artery. So this is what they call the widowmaker right here. Any clot here, you affect all this area, which is mainly the left ventricle and the septum itself. Okay. So the circulatory system, the blood, red blood cells, you have red blood cells, white blood cells, platelets, and serum. Now, I always use the analogy of, I like to drive around when like when we go on trips, I rather drive than fly. And I always use the analogy is that the red blood cells are your 18 wheelers, cars, and everything that are going through the road. And the roads are the blood vessels themselves. Okay. And basically, white blood cells are your DPS troopers. They're your police officers, your sheriff's office, your ATFs, and all these other people that are right there, making sure that nothing goes wrong. The platelets, the platelets themselves are the people that are fixing the road. The slow men working, where it says slow down, men working. These are the guys that are fixing the road itself. And of course, the serum will be the pavement itself, the black tar. Okay, the blood itself, platelets play a role in the cardiac emergencies through their role in blood clotting. It has to have a couple of other factors in there, but they actually help to clot blood. Then if you want that little clot that formed to actually stay and be long lasting, then you have to worry about certain chemical or certain I want to say hormones, but they're not hormones, they're enzymes. They're not even enzymes. They're fibrous connective tissue that basically causes them to actually stick together. So platelets, thrombin, and fibrin are components of clots. A thrombus may form at the site of a plaque in a coronary artery. And the plaques themselves, if you want to think about it, and that's why I usually tell you, little kids don't die of heart attacks because they haven't had all those years. So let's say this is a blood vessel, all those years of actually having bad eating habits or whatsoever. So sometimes uh, cholesterol forms a plaque. Okay. So that actually diminishes the size of the artery itself, right? So instead of having all this area opened up, now it's just this area right here. So what happens is that if you get what we call a Prince metal angina, which basically Prince metal angina, and it's not the guy formerly known as Prince. It's just called Prince metal angina. Or are you guys too young for that? Kind of causes the blood vessels to shrink. And if you have plaque, you get a heart attack. Though usually the massive, what they call the massive heart attacks are caused by Prince metal angina. It's more common, I believe, in females than in males. Uh, but you give nitro and it actually dilates back. But if you have somebody that didn't have a Prince metal angina, they're gonna have chest pain because not enough blood now is going through this area. And what happens is that they're gonna start having chest pain because they're not the tissue itself, let's say the heart tissue itself, is not getting enough blood. So it starts making you have chest pain. And the chest pain that we feel when you're having a heart attack is called angina pectoris. Okay. So what happens, it starts doing all these chest pain situations where, in if you don't have if you don't have this constriction of the blood vessels, you have a person that might have been suffering um, for a few months of chest pain, let's say. I actually talked to somebody, it's like, hey, well, how long have you had this chest pain? For about a year. And, I'm looking at it, it's like, you haven't died yet? And he's, once you start having that little difficulty there, you might want to get yourself checked out because you might actually have a plaque. And if this plaque ruptures because of the pressure that is being put against it, then you have a clot that forms. Now, guess what? So if you have this clot that forms right there, then you have complete occlusion to a certain part of the heart. So what do you do? What's the first line of medications that you give a patient complaining of chest pain?
Chewable aspirin.
Okay, so aspirin, non-enteric aspirin, right? And what else?
Nitro.
Nitro, okay? So what nitro does, it's a peripheral vascular dilator. So what it does, it opens up the blood vessels. So instead of having the blood vessel this big, now you have it maybe this big. So now you can actually get more blood actually flowing through it, making the muscle itself happy. Now that's nitro. Aspirin, it's a blood clot breaker. So what happens is you give aspirin, you start breaking down this clot. Okay, and then it just moves on. Now, there's another medication that you give that's very important when it comes to this. What other medication do you give? Starts with O, followed by X, followed by Y, followed by G.
Oxygen.
Oxygen, there you go. So you give oxygen because this little fellow here, which is the heart muscle, is not getting enough oxygen and nutrients, right? And if it doesn't get oxygen, chances are it's building up with carbon dioxide. So it's not actually getting rid of it either. It's not getting rid of carbon dioxide. So you give oxygen. Now the only thing is that's actually, and I'm surprised. A few years ago, the American Association started talking about something that is called free radicals. And free radicals, all it is just electrons that are bombing themselves out of the oxygen because let's say there's this clot that formed right here. Now you have oxygen going here, but it's getting stuck there. So now you're getting more oxygen, more oxygen, more oxygen. You have a piece of the blood vessel highly concentrated in oxygen. And once it gets highly concentrated in oxygen, you break that clot, it's going to go at releasing all these electrons, causing heart damage. So that's why it's important for you to actually, of course, in the paramedic level, we use the electrocardiogram to find out. But in your level, you can put a pulse oximeter and find out what your fingers are saturating at. And if you need oxygen, you give oxygen. If you don't, you don't. Because you can still give positive pressure ventilation with oxygen through a BVM with pure oxygen, or you can give it at 21%. It just depends. Now, it doesn't really, they didn't really go too much into it, but I know in medical school, it was like, hey, you need to be careful for when we're talking about reperfusion syndrome, which basically going to cause more damage to the heart than if you didn't do any, if you actually would have done anything. Yeah. So this is what the fatty plaques actually look like. They start getting bigger and bigger and bigger because we eat a lot of junk food, McDonald's, gas station food, whatsoever. So we start developing all these little plaques there. Now they might actually close up the blood supply, or they can actually rupture, and then you form thrombus that will actually get stuck. Cardiac contraction, you have electrical impulses that actually generate the SA node and travels first to the atria, causing the atrial contraction, then the ventricles causing ventricular contraction or systole. We do have, and I kind of showed you a little bit the graphic. Now, the electrocardiogram itself, also known as the ECG, is a graphic representation of the heart's electrical activity. Okay, electrical activity includes depolarization and repolarization. Okay, depolarization is contraction, repolarization is relaxation. The electrical activity is detected in the skin surface by the electrodes that put on there. Remember that we put these electrodes, that's called salt, pepper, ketchup, 3 different colors. And if you have the 4 wires, it's salt, pepper, ketchup, pickles. So we have the first portion of the contraction, I mean the impulse being a P wave. Now a P wave is defined as rounded. It can also be defined as small or inverted. But if you see a square P wave, that's not a P wave, it's a flutter wave. QRS now this is atrial contraction. The QRS complex is ventricular contraction, and the T wave is ventricular repolarization or relaxation. The only reason you can't see atrial repolarization or relaxation is because it's hidden within the QRS complex. Hypoxia or damage to electrical conduction system can actually cause improper functioning of the heart. Uncoordinated firing of ventricular impulses can actually lead to PVCs, also known as premature ventricular contractions. And these are the ones where if you talk to somebody who's having PVCs, you ask them, "Hey, what is it that it feels like?" Because you can get them confused with palpitations, but PVC basically, also known as premature ventricular contraction. It's a contraction that happens before it's supposed to. Now, a lot of times, our body does it normally. You'll be tired, you're just dragging. All of a sudden, you throw a couple of PVCs, causing your heart to speed up a little bit. But when you have like 2 in a certain time or whatever, then you might start thinking that it might go into ventricular fibrillation, ventricular tachycardia, or ventricular fibrillation. Oh, damn. Blood pressure. So basically, systolic blood pressure is measured during the contraction of the heart. And when we're talking about the contraction of the heart, we're talking about the contraction of the ventricles. So systolic blood pressure is contraction of the ventricles. Diastolic is when you have the ventricles relaxing. Okay, the degree of resistance of blood vessels affects blood pressure itself because, well, you have to work twice against trying to get that blood out. The inadequate circulation results from hypoperfusion or shock. In other words, remember, how many different types of shocks do we have? We went over them last week.
3.
We have more than 3 actually. But if you start thinking about it, one of them is gonna be anaphylactic shock. Then the other one's gonna be distributed shock. And then the one's gonna be obstructive shock, and then the other one's gonna be neurological shock, and whatsoever, right? And all these actually, or hypovolemic shock.
There's 5, right?
Huh?
There's 5 main ones.
The main ones, and then basically it all depends on if you have a clot restricting blood from going through, or you have dilation of the blood vessels, or you have loss of blood or plasma. That's what gives them a specific situation, right? Or if you're having an allergic reaction, basically your blood vessels just dilate and they bring down your blood pressure. Okay. Cardiac related emergencies are a significant problem. EMS plays a role in actually reducing the death rate associated with heart attacks. So we're there to interfere with death. Time is critical. Early recognition is key to effective treatment. Now, collectively, cardiac conditions are referred to as cardiac compromise. The sooner the patient receives treatment, the better the prognosis. In other words, the better the outcome of the patient is going to have. Remember, there's a time period where you can actually revive the cells that are getting ischemic. But once the cells die, no, it doesn't come back. So now we have arteriosclerosis as opposed to atherosclerosis. And the spelling is almost the same, but arteriosclerosis is inflammation disease that actually affects the arteries themselves. The inflammation process may actually eventually lead to the development of thrombus, and those clots, and occlusion of the blood vessels. Arteriosclerosis of the coronary vessels is called coronary artery disease, also known as CAD. Acute coronary syndrome includes unstable angina and myocardial infarction. Now, we do also have one of them that's called stable angina. So we have stable angina, unstable angina, and then myocardial infarction. Now, stable angina is when you're working out or something, all of a sudden your chest hurts, you sit down and rest, and it goes away. Or if you're you have to be doing something strenuous for you to get it. And once you relax, it goes away. Well, unstable, it starts off where you're actually resting, doing nothing, and it doesn't go away. Myocardial infarction is basically cardiac death. It leads to them. You have narrowed arteries lead to myocardial ischemia. The typical response to myocardial ischemia is chest discomfort, also known as angina pectoris. So angina pectoris results from reduced oxygen delivery to the myocardium. It results in chest discomfort, usually occurs during physical or emotional stress, and generally relieves with rest and nitroglycerin. Now, there are people that are out there that have their own nitroglycerin, they take it, and it doesn't work. So how do you know if nitroglycerin is working or not working? Because you can only give up to 3 nitroglycerin pills. That's it. And there's indications and contraindications. An indication would be chest discomfort. A contraindication would be a blood pressure of less than 90 systolic. So if you have 90 over 6, or let's say 80 over 60, you cannot give nitro because nitro is going to bring down your blood pressure. So let's say you have an occlusion to these blood vessels right here, you start getting chest discomfort. That's right here. Now, I want you to remember, from a large blood vessel, bifurcates into smaller blood vessels. So that's where usually the clots get affected at. And actually, you get to see a better picture of the coronary arteries leaving the aorta right here. Right side and left side. Okay. Angina pectoris, when angina discomfort is prolonged and actually worsening, or occurs without exertion, is called unstable angina. Okay. Women, diabetics, and elderly may actually not have a typical presentation of angina because of their diabetes or whatever, or their age, they have what we call a silent heart attack. Discomfort is more diffuse and or does not occur. And patients may actually complain of shortness of breath, fainting, weakness, and lightheadedness. I know that I've always known that if you have an older gentleman constantly fainting, consider it a heart attack or cardiac compromise than anything else, and prove it otherwise. Because these people are getting what they call a silent heart attack. They're not gonna show you typical signs of heart attack. Okay. Emergency medical care for angina, manage the airway and breathing. Supplemental oxygen at 2 to 4 liters per minute. If the PO2 is actually less than 94. Now, supplemental oxygen at 2 to 4 liters per minute. How would you give this one? Through non-rebreather mask, nasal cannula, or a simple face mask, or BBM?
Non-rebreather.
Nope. 2 to 4 liters. That's nasal cannula territory right there. Nasal cannula. Okay. Now, I would ideally, if somebody's complaining of chest pain, I am not going to give them 2 to 4 liters. I'm going to give them 15 liters per minute and a non-rebreather mask. But when they mention 2 to 4 liters, automatically, this is the only device that you can actually put for actually 2 to 6. If you get a non-rebreather mask and you put it at that, you're not giving them any oxygen. You're actually making carbon dioxide. It says the patient with nitroglycerin, if their systolic blood pressure is greater than 90. So that's a contraindication. If less than 90, then you have to worry about it. You can't give it to them because you're going to make their blood pressure go to 0. If protocols allow, administer 160 to 325 milligrams of aspirin. And it has to be chewable aspirin. Okay. Acute myocardial infarction typically occurs when a plaque ruptures, thrombus forms within 20 to 30 minutes of inadequate perfusion, heart muscles begins to die. Ischemia may actually lead to dysrhythmias and sudden cardiac death. Treatments are available to restore myocardial perfusion. Success in treatments is time dependent. In other words, the sooner you do it, the sooner they're out of it. Diabetics, the elderly, and women may actually complain only of shortness of breath, nausea, lightheadedness, or weakness, or fainting, also known as syncopal episodes. So here's a person that might actually, the difference between an angina pectoris and infarction. The location is substernal or across the chest. And for myocardial infarction should be the same. For angina pectoris, the radiation, neck, jaw, arms, back, and shoulders. And for myocardial infarction, the same. Nature of discomfort, dull or heavy discomfort with a pressure or squeezing sensation. And he's doing your typical, I'm having a heart attack sign right here. He's grabbing his chest. Same, but actually maybe more intense. The duration, usually about 2 to 15 minutes, and then it goes away after the activity stops. And with a heart attack, it lasts a lot longer than 10 minutes. Other symptoms, usually none. With myocardial infarction, your sympathetic system kicks in, so you start sweating, you start perspiring, pale gray color, nausea, weakness, dizziness, and lightheadedness. Precipitating factors, extremes in weather exertion and stress can actually cause this. And usually with the myocardial infarction, usually none of these. Stopping physical activity, reducing stress and nitroglycerin. Nitroglycerin may actually give incomplete or no relief if you're having a heart attack itself. So acute myocardial infarction, emergency medical care, have the AED available, manage the airway and breathing, administer O2, administer nitroglycerin, administer your aspirin, notify the receiving facility coming in with a chest painer, and if you can, request an ALS unit if available so they can actually start an IV and give better medications. Aortic aneurysm dissection. Now, aortic aneurysm is basically part of the aorta tearing apart or rupturing. Okay, so in aortic aneurysm, you have a weakened area of the aortic wall and it dilates. Rupture may actually occur in rapid fatal internal bleeding. Often usually occurs in the abdominal region, which is your AAAs. Ascending aortic aneurysm. Or it should be descending. But you have the ones that usually occur and the blood vessels right in your lumbar area. So basically, this right here is an aneurysm, like a ball in a tire. Once it bursts, it's not called an aneurysm, it's a rupture. So you have aortic aneurysm or dissection. Aortic dissection blunts and tears the inner lining of the aorta itself and separates the layers of the heart and wall. When you have the rupture itself, often not yet, often occurs in the thoracic region. And pain is severe, sharp, tearing in nature. And that's one of the things I'm going to tell you. It feels like something tore in there. Often experienced in the back, flank, or arms. You guys know, I had a student that just took the exam, passed it, the EMT basic exam, and he asked me, what is a flank? You guys know where your flanks are at?
Like a fajita?
Well, no, where in your body where the flank would be.
Isn't it like under your rib?
It's actually on the sides. Yeah, well, and under the ribs, but on the sides themselves.
But like on the inside.
Yeah.
But like on the inside, right?
Yeah. And what happens is that you have pain in your flank.
Isn't that where like
I just didn't know that it was one of those. I mean, to me, it's like a flank. Well, I know what a flank is, but I didn't know that. Newer generations don't know that. So at this point, you have your, this is a typical artery itself. Then you have the tear that occurs, and blood starts accumulating here, causing it to balloon out. If you tear enough, it's going to rupture. So this is that dissection right there. Aortic aneurysms and dissection, emergency medical care conditions require immediate surgery. And guess what you can't do in the field? A surgery. And if you suspect it, do not give any aspirin. As soon as they tell you it feels like a tearing sensation, the first thing I would do, guys, grab both of the wrists with both of your hands, okay? Grab the wrist and compare the pulses. So you're grabbing the wrist and you're comparing the pulses. If the one on this side is slower than this one, they have a dissection in there. Basically because the blood is not circulating as much because of that dissection. So you compare the pulses in each wrist. I'm going to tell you one thing. I had a patient once, and I suspected that this person was having an aortic aneurysm. And that's not because he told me I feel a tearing sensation. It's because when I checked his pulse, it became a habit for me to check the pulse, count it, see the strength or whatever, and then compare both wrists, right? And it became such a habit that I would do it on every single patient, whether he was being transported back to the house or whatever, right? So I noticed that on this guy, and I asked him, "Hey, have you ever been told that you might actually have an aortic aneurysm?" Oh, I don't know what that is, blah, 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 blah. So basically I checked, nada, right? He never told me anything, but I suspected it. So, and he was coming in chest pain. So I told him, I'm going to go ahead and give you some oxygen, and I'm going to give you nitro. So when I got to the hospital, I get my report, I got to the hospital, the doctor asked me, hey, how come you didn't give me any aspirin? They get, doc, I think this guy has an aortic dissection. So what makes you think he has an aortic dissection? So the doctor looks at the patient and tells him, have you been diagnosed with an aortic dissection? Guess what the patient told him? Yes, about a year
Yes.
ago. Pinches mentirosos. Patients are liars, man. And I was like, with my mouth open, going like, seriously, dude, I asked you like 3 times and you said no, no, no. And then you come and tell the doctor, oh, guys, by the way, I have an aortic aneurysm. And I'm thinking like, I am cussing this guy out in trilingual, because I know a little bit of Portuguese, and the first thing I learned was the bad words. Spanish, the first thing you learn is the bad words. English, well, you already know them. Of course, I'm Mexican, so I talk Spanish, and I was doing combinations in different languages because he made me look bad. So, and the doctor says, "Hey, good call, good call, good call." I was like, "But this idiot." The doctor just looks at me like, "Hey, calm down. It's okay. Patients are liars. They don't want to find out what they have." They get, just for that, I'm going to charge him for another IV, which he probably didn't even pay for. Acute coronary syndrome in females often occurs in older age than in males, with twice the likelihood of death. Classical findings: dull sensation, substernal, chest pain and discomfort, respiratory distress, nausea, vomiting, and diaphoresis. Vomiting is one of the weirdest things that I've ever seen with any type of cardiac condition, specifically in females. Even with what do you call it? With I read of a couple of cases that patients that came in with a ruptured aorta or a dissection. One of the first things, they had flu-like symptoms, and they started vomiting. Okay. Non-classical findings: neck ache, pressure in the chest, pains in the back breast and upper abdomen, tingling in the fingers, unexplained fatigue or weight gain, and insomnia. They can't sleep. Dangers of administering too much oxygen in the acute. This is when we start talking about your free radicals. Too much oxygen can actually increase cell damage in certain situations. The return of oxygen to an area that does not have any oxygen, it'll suck up whatever oxygen is in there, and actually increases the free radical production, giving oxygen only when the SpO2 level is less than 94. That's something that you're probably going to be attacked with in the National Registry. They're going to give you the SpO2 level, and they tell you, this guy's suffering from severe chest pain and whatsoever, but his SpO2 level is greater than 94. What do? Well, you don't give him that much oxygen, as opposed to giving him a lot of oxygen. Other causes of cardiac compromise: heart failure. And heart failure is usually because you had a heart attack or something, and part of your heart itself is not working anymore. It usually occurs when the ventricle can't adequately eject blood. It could be because of an enlarged heart. Okay, may be caused by a heart attack, heart valve problems, hypertension, pulmonary embolism, cardiac rhythm disturbance, and some drugs. Heart failure. Left ventricular failure reduces blood flow and perfusion throughout the body. Blood backs up behind the left atrium, increasing the pressure in the pulmonary veins. Okay, the pulmonary capillaries leak fluid, resulting in pulmonary edema, which basically now makes it hard for you to actually get oxygen into your system. So now you have left ventricular hypertrophy. And basically what it means is that the muscle itself has become a lot thicker so when it becomes a lot thicker, it doesn't give it enough space to actually collect any blood and eject it out. Other causes of cardiac compromise: heart failure. Right ventricular failure may be caused by a failure or left ventricular or COPD, which is basically congestive obstructive pulmonary disease. Signs include peripheral edema, JVD, and enlarged liver. Now, how can you find out if the liver is enlarged, guys? And this is something they don't teach in EMS, not even in the paramedic level. You ask the person, blow out all the air out from your lungs. So they'll go again. You tell them, hold it. You get your fingers, you put them underneath the rib cage. Then you take a deep breath, and you're gonna feel the liver. And if it feels hard, then they might actually have cirrhosis of the liver or an enlarged liver. Cardiogenic shock can actually occur when the left and right ventricular failure is present. So you have pure right-hearted failure, and then you have pure left-hearted failure. And systolic blood pressure might be low and normal and pure right-hearted failure, and it should be normal to high and left-hearted. Breath sounds are clear sounds, and then in the other one, you're going to have wet lungs, and also expiratory rails. And in peripheral edema, you have JVD and peripheral edema, which basically is swollen ankles and whatsoever. What we call cankles now, because they're swollen, or no JVD or peripheral edema. So basically, when we're dealing with, let me see if I can see this because I have something stuck in. Signs and symptoms of congestive heart failure. I think my wife is watching a Christmas movie. Okay, mild. Oh, no, the other way. No, the other way. Okay, mild or severe confusion, cyanosis, tachypnea. What is tachypnea, guys? Tachypnea is heart rate, fast heart rate, above 100. Okay. Oh, I'm sorry. Tachypnea is fast breathing. I'm sorry. Tachycardia is fast heart rate. May actually cough, pink sputum. And pink is, once you start coughing and you start seeing the little tinges of blood within that sputum, then they have CHF, which is congestive heart failure. The heart's not pumping the blood out, so it's backing up into the lungs. Low, normal, or high blood pressure, rapid heart rate, and a desire to sit upright, only because you're getting the lungs filled up with oxygen. I mean, with fluid. You have distended neck veins, which is a late time crackles, which is a wet lung sound, shortness of breath, pale, cool, clammy skin, abnormal distension of the abdomen or abdominal distension, and pedal or lower extremity edema. Now, when I first looked at this, I thought, oh, the little baby in the little shoes. Nah, dude, this is an adult with cankles. It's gotten so swollen that you can't tell the difference between a cankle, where the cankle is, not cankle, the ankle is and the foot is. So they become very thick. Now, what you do with these patients, get your thumb, press down, and any area, if it stays sunken in, that's peding edema, long-term issues with the heart not being able to pump sufficient blood out of there. And usually happens to people that have been seeing a lot, or they've been patients that have actually not exercised or whatsoever. This is what jugular vein distension is. This is the ear. This is the jaw. You get to see this blood vessel, which is the jugulars, popped out. And usually it's at about a 45-degree angle or below that. Okay. Other causes of cardiac compromise, heart failure. Emergency medical care for heart failure includes treating as an AMI, with giving oxygen, nitro, and aspirin. Positive pressure ventilation may actually be required, supplemental oxygen according to the American Heart Association guidelines, and consider the need for CPAP. Now, I haven't seen anybody locally around here carrying CPAP, but I've been seeing a lot of books mentioning it. So there's going to have to be some training on that. Other causes: hypertension is associated with emergency conditions, systolic blood pressure, excuse me, greater than 160, and then diastolic above 94. So 160 over 94 is considered double whammy at this point. In an assessment, consider the patient's usual blood pressure. So That might be normal for them. Cardiac arrest, the heart is pumping inadequately or not at all, and actually no pulses can be felt. May be caused by acute coronary syndrome. Excuse me. Or may actually be caused by acute coronary syndrome or other causes. Yeah. Nitroglycerin is a potent vasodilator that was dilates and increases coronary blood flow and actually reduces workload of the heart. EMTs may actually assist the patient with nitroglycerin tablets or sprays. They comes in two different forms. Same dosage, but different forms. Your systolic blood pressure must remain above 90. So let's see, if you have a person that has a blood pressure of 120 over 80, and he's complaining of chest pain, you give him nitro. Right before you give the second dose of nitro, because it didn't relieve the pain, if his blood pressure is less than 90, you cannot give it anymore. Okay, nitroglycerin must not be given to patients who have taken a drug for erectile dysfunction within 24 hours or longer, or some drugs. So if they've taken Viagra or Cialis or whatever, you can't give nitroglycerin because, as it is, Viagra and Cialis brings down the blood pressure. Now you're going to give this medication, is going to do 2 or 3 times the effect that it's supposed to have. Do not administer if the heart rate is less than 50 or over 100, because, and the reason I'm telling you is, if it's over 100, they might be going through what we call a compensatory mechanism. The heart's trying to maintain the blood pressure. And you can only give up to 3 doses total, may actually be administered in 3 to 5 minute intervals if pain isn't relieved. Now remember, nitro is not a pain reliever. It's a vasodilator, so it causes the heart to get oxygen, reducing the pain. So click on the condition that would make a patient with chest pain discomfort ineligible to receive nitroglycerin. Age over 65 years of age. Heart rate of 60. Viagra taken 1 week ago, or systolic blood pressure of 88 millimeters of mercury. And this was easy.
D.
Letter D. Okay, because the Viagra has to be within 24 hours. Heart rate 60, it has to be below 50, and the age doesn't really matter. But systolic blood pressure less than 90, yep, it matters. So administering nitroglycerin, take a blood pressure, check a pulse, talk to the patient to see if she's taken any of the medication before. Call your medical director so you can actually get what do you call it? Permission to give nitroglycerin. Look at remember the 5 R's, right? Dose, right? Route, right? Whatever, right? So make sure that the pills are actually not expired. Ask them to lift up their tongue, and then you put it under their tongue and have them close their mouth. And that should get absorbed within the blood vessels that are on the bottom of the tongue. Okay, if you give a spray, it's the same thing. They spray under the tongue, and it's like a little pump that just sprays the same amount of medication. You take the blood pressure to see within 2 minutes to see if it's actually lowered the blood pressure. Now, if nothing happens, ask the patient, do you normally get a headache when you take nitroglycerin? And if they say yes, ask them, did you get the headache right now? If they say no, then the medication is not working. It's deactivated. Pediatric considerations when it comes to pediatrics and geriatrics. Problems with usually due to congenital heart noise, malformations in the heart itself, which is one of them is the sinuophilic teratology. Problems usually occur due to congenital heart failure conditions, but not due to coronary syndrome because, hello, kids don't have plaque that forms at that young age. Cardiac arrest is usually due to airway compromise or respiratory failure. And geriatric patients present the highest number of patients who treat you treat and experience some of the acute coronary syndrome. So if you have a history of diabetes mellitus, a geriatric patient with diabetes has long-term damage to nerve endings of the body, so they can't feel anymore. That causes this causes the typical pain from an MI not to be perceived by the body. If at all, the diabetic patient, therefore, the diabetic patient experiencing an MI may complain only of respiratory distress, nausea, dizziness, and standing or even excessive weakness and dyspnea on exertion. It is important that the EMT to identify the patient with diabetes as a potentially having an acute myocardial infarction or cardiac event. Okay, a history of trauma in the geriatric patient is a trauma patient. There might be a high index of suspicion of cardiac involvement as well. Geriatric patients who actually are traumatized can actually progress quickly into cardiac arrest and do not respond when when typical interventions are given. Geriatric patients with head trauma, chest pain, abdominal trauma, or extremity trauma with severe bleeding are especially susceptible to cardiac arrest. Any type of history with asthma, patients with a history of asthma goes into cardiac arrest. The cause may actually be acute bronchoconstriction, basically not getting any oxygen into the system itself. So then they die of hypoxia. History of COPD, elderly patients commonly have some of the COPD, emphysema, or chronic bronchitis. The arrest may actually have been caused by the exacerbation of COPD, which led to hypoxemia, acidosis, and then the arrest itself. Call for ALS backup so they can maybe intubate the patient or start IVs on the patient. So basically, assessment and general care and general guidelines. It says the baseline approach, cardiac compromise, and acute coronary syndrome. Consider dispatch information, do a scene size up, a primary assessment, categorize, and as the patient is responsive or unresponsive, if they're awake or not awake, or cardiac arrest. Begin CPR in a cardiac arrest and apply the AED for responsive patients. Assess the airway, breathing, and circulation and oxygenation. Secondary assessment, obtain a history, use the OPQ-RST. Ask about contraindications to fibrinolytic therapy. In other words, can they get fibrinolytic therapy in case? Anticipate the patients may actually downplay their symptoms because they're scared to find out what they have. Treat the following as cardiac compromise patients with angina less than 20 minutes, recent onset of progressively worsening angina, or nocturnal angina. If they're resting and they had chest pain, they're not exerting themselves. So basically, that's considered an unstable angina. Treat the following for cardiac compromise: angina unrelieved by rest or 3 nitroglycerin tablets over 10 minutes, chest discomfort lasting longer than 5 minutes or 10 minutes after rest. Assessment-based approach, consider atypical presentations. Not all symptoms have to be present for acute coronary syndrome to be actually present. Your physical exam and baseline vital signs, check the pupils, oral cavity, and neck. And this is basically your typical areas where you're going to feel pain when it comes to cardiac compromise. The middle of the chest, the midline chest, neck, and jaw area, middle of the chest and shoulder, upper abdominal, or also known as the epigastric area, large area in the chest, and both arms, just the neck and the jaw, both arms and right shoulder, and then basically between the shoulder blades themselves. physical exam and baseline vital signs. Check the chest, lower and upper extremities, posterior body, and vital signs. So you can have them as a baseline. Significant signs and symptoms, I'm sorry. Chest discomfort or pain, which may actually indicate epigastric pain. Sudden onset of sweating, cool, pale skin, difficulty breathing, and lightheadedness or dizziness. Signs and symptoms, anxiety or irritability, feeling of impending doom, which is very typical to patients that are having a heart attack. Abdominal pulse, and nausea and vomiting. Yeah, usually abdominal pulse, if you check the abdomen and you feel a pulse there, is usually a descending aortic aneurysm. Emergency medical care, did I say descending? Ascending, I'm sorry. Provide reassurance and place the patient in a position of comfort. Now, what would be a position of comfort when it comes to these people? Semi-foulers.
Sitting up straight, yeah.
They won't let you lie them down, I can tell you this much. This is the patient who has prescribed nitroglycerin, administer aspirin according to protocol, and call for ALS backup. So they can meet you halfway or they can meet you there at the scene. Assessment-based approach, cardiac compromise, reassessment. Patients with acute coronary syndromes can actually deteriorate to cardiac arrest, and closely reassess breathing and pulse. Assessment-based summary, assessment, and care. So that's it for this chapter. This is the only chapter I was going to cover today, guys. Do you guys have any questions?
No, sir.
Are you sure?
No, sir.
Okay. Then I'll just,
the video is gonna be up the beginning of the class that I missed right there.
yeah, no. I'm gonna as soon as I get it downloaded, I'm gonna upload it to YouTube and I'm gonna go ahead and put it out there. Did you get access to Google Classroom?
No, I was gonna ask you for another.
Dude, that's what you told me that's what you told me on Monday.
No,
Oh, no, sorry, Friday.
Yeah, on Friday. I clicked on the invitation, but it had already expired, so that's why I was gonna ask you for another one. Just
Me too. I need another one.
Yeah, I'll send it. I'll send it again.
Okay.
All right. I forgot that they do expire after a certain amount of time. No. Then I'll get to see you on Wednesday.
Yes, sir.
Okay, you take care.